Episode 11 Proximal Control Vascular Surgery Exam Prep. Upper limb ischemia and Raynaud's phenomenon. FRCS and European Board Vascular Surgery Exam Focused Teaching. Welcome back to Proximal Control. I'm your host, Mo Mia. This is the podcast where we prepare for the vascular exams the way we practice as a day one consultant with structured judgment and control. Because in vascular surgery, control is everything. Today we are doing upper limb ischemia and we are keeping it focused on what actually gets tested. We'll cover acute upper limb ischemia, then move into chronic atherosclerotic upper limb disease, including subclavian steal and coronary subclavian steal. And we'll finish with rapid fire SBS and short oral style scenarios. Why this matters in the exam? The aim today is simple. If an examiner say, talk me through upper limb ischemia, you give a clean, structured answer and you don't get trapped. Let's start with exam safe definition. In one go. Acute upper limb ischemia is a sudden decrease in limb perfusion threatening limb viability, most often from embolus or acute thrombosis. The clinical assessment is best structured as viable versus threatened versus irreversible, because that dictates urgency and the next step. Chronic atherosclerotic upper limb ischemia is progressive flow limitation, usually subclavian or innominate stenosis or occlusion, sometimes axillary. And the key point is the arm often has symptoms of claudication, rest pain, tissue loss less commonly than legs, but it can present with Steele syndrome and with access-related or coronary graft-related problems. Now let's talk about epidemiology and risk factors. Acute upper limb ischemia is more often embolic than lower limb, and a classic background is atrial fibrillation or another cardiac source. You should always say upper limb emboli frequently lodge at the brachial bifurcation, and because the limb tolerates ischemia differently, you must not assume less urgent. You still treat it as an emergency. For chronic disease, atherosclerosis dominates. And the key point is that left subclavian disease is more common than the right, and subclavian stenosis is commonly proximal to the vertebral origin, which is why steal happens. Risk factors are the standard atherosclerotic ones, but the exam scoring comes from saying the specific ones: prior CABG with Lima graft, ipsilateral AV fistula or dialysis access, and prior arch or neck interventions, because these strongly influence your management and urgency. Now let's talk about pathophysiology. First, acute upper limb ischemia. Think of it as two big buckets and say it clearly. First, embolus, sudden occlusion in a previously normalish artery, no collateral recruited, abrupt pain and deficit. Second, thrombosis, acute occlusion on chronic plaque, often more collaterals, sometimes a bit less dramatic, but still limb threatening. And there's the high yield line. Upper limb collaterals are better than lower limb, so the limb may look deceptively okay, but motor deficit or severe sensory loss still remains threatened limb and you act. Now, chronic atherosclerotic disease and steal. For chronic subclavian stenosis, your flow is limited to the arm during demand. If the stenosis is proximal to the vertebral origin, The arm steals blood via retrograde vertebral flow, so you get vertebrobasilar symptoms, especially with arm exercise, that's subclavian steal syndrome. So, in duplex ultrasound, flow reversal in vertebral artery is an important clue. Now, the extra exam trap: if the patient has a Lima graft to the LAD and there is a subclavian stenosis, that can reverse flow through the Lima, which is left internal mammary artery, during arm exertion, giving angina or ischemia, that is coronary subclavian steal, and it's an important topic to know. Now let's talk about some relevant anatomy. Upper limb acute embolas, think axillary and brachial, with classic lodging around the brachial bifurcation. For chronic disease, think innominate subclavian, especially proximal to vertebral origin, and the relationship to Lima. And for procedures, you must say, when you are treating proximal subclavian disease endovascularly, your access strategy and protection of vertebral or cerebral circulation is the reason examiners like to test. Now let's talk about the natural history. The big complications in acute limb ischemia are limb loss, nerve injury, and systemic complications if reperfusion is delayed. But in the arm, limb loss is generally less common than in legs, provided you act early. Still, threatened limb can deteriorate quickly and irreversibly, so you must triage properly. In chronic limb-threatening ischemia, untreated proximal disease can lead to progressive arm symptoms, but the complications examiners want are posterior circulation symptoms, TIA-like symptoms in steal physiology, and myocardial ischemia in coronary subclavian steal. Let's talk about clinical presentation and red flags. In acute upper limb ischemia, you can use the classic ischemia symptoms but deliver it like examiner answer. Pain, pallor, pulselessness, then the two-limb threateners, sensory loss, and especially motor weakness. Motor deficit means threatened limb until proven otherwise, and if there's fixed mottling and profound anesthesia, think irreversible. Red flags, you must say: motor deficit, compartment tightness after perfusion, a patient with AF not anticoagulated, bilateral symptoms or neurosymptoms suggesting a proximal central process instead of upper limb ischemia. Next, chronic atherosclerotic upper limb disease. Symptoms split into arm claudication, fatigue, rest pain, tissue loss in advanced disease. Neurological vertebrobasilar symptoms in steal, indigenous syncope-like episodes, visual disturbance often triggered by arm exercise. Angina in coronary subclavian steal if Lima graft is present. And here's important one to remember: if you see arm symptoms, posterior circulation symptoms, plus a bigger interarm blood pressure difference, think subclavian stenosis with steal. Assessment framework: how to speak safely in the exam. When asked how would you assess, First, I decide if it's acute limb-threatening ischemia or chronic presentation. Then I assess limb viability clinically. Then I start immediate safety steps and parallel track investigation, starting with bedside Doppler, then duplex, then cross-sectional or catheter angiography depending on urgency and whether intervention is planned. Now, add the upper limb specifics. For chronic disease, you should always compare both arms, pulses, bruit, neurology, and measures blood pressure in both arms because a significant difference supports proximal disease and frames steel. Now, what are the differentials? For acute embolus versus thrombosis, aortic arch, large vessel source, trauma or iatrogenic thrombosis, thoracic outlet, related arterial events. For chronic, large vessel atherosclerosis such as subclavian or innominate, thoracic outlet syndromes, arterial, vasculitis and inflammatory disease, embolic microvascular cause. How would we investigate? First, the first line is handheld Doppler and a quick vascular exam. Then duplex ultrasound. In acute ischemia, duplex helps you distinguish embolus versus thrombosis and locate the level of occlusion if the limb is stable enough. In chronic subclavian disease, duplex is high yield because it can show vertebral flow direction, and retrograde vertebral flow supports steel physiology, and this is very important for the exam. Often you may be shown a duplex scan with vertebral flow reversal, and at that point you pick the diagnosis up. In chronic disease, do not stop at subclavian stenosis. You must define whether it is proximal to the vertebral origin because that's what links it to neurological symptoms. Let's talk about imaging. If intervention is being planned, you will need anatomical detail, CTA or MRA for mapping proximal disease and planning endovascular versus open. Catheter angiography if you're proceeding directly to intervention or if non-invasive imaging is inadequate. Okay, in acute upper limb ischemia, if the limb is clearly threatened and the diagnosis is clinical, do not delay treatment for fancy imaging. That's a classic error. Now, how would we manage acute and chronic upper limb ischemia? Let's talk about acute upper limb ischemia first. So, resuscitate and treat pain. That is the first thing that you do. Second, immediate systemic anticoagulation with heparin unless contraindicated, and do not wait for imaging to start. Third, classify viability. If viable or marginally threatened, you have time for duplex or CTA to plan. If threatened, you go to urgent revascularization. What are the options? Open embolectomy. This is the classic high-yield procedure. For suspected embolus at the brachial level, you describe for suspected embolus at the brachial level, incision in the antecubital fossa to expose the brachial artery and bifurcation, controlled arteriotomy, passive Fogarty catheter proximally and distally to clear clots, confirm back bleeding and distal flow, close the arteriotomy and confirm perfusion clinically with Doppler, and then anticoagulate and investigate the embolic source. To treat it as an emergency, heparinize early and restore flow promptly to prevent nerve and muscle loss. Do not stop after proximal clearance. You must ensure distal clearance and assess for ongoing distal embolization. What about thrombolysis or endovascular options? If the anatomy or clot burden makes open embolectomy less suitable, or the occlusion is more distal, catheter-directed therapy may be considered in selected patients. But you must balance bleeding risk and timing. And again, the key exam point is do not delay threatened limb. What about aftercare? You must say you will continue anticoagulation as appropriate. Look for the sources such as ECG for AF, echo if indicated, and optimize vascular risk factors. A common issue is recurrence, so explicitly, if you don't address the embolic source, you have not treated the disease. Now let's talk about chronic atherosclerotic upper limb ischemia, including steel. First decision, do you need to intervene or not? Many patients with subclavian stenosis are asymptomatic, and the trigger for intervention is usually symptoms: arm claudication, limiting function, vertebrobasilar symptoms in steel, myocardial ischemia in coronary subclavian steel, or access-related problems like dialysis, fistula flow demands. Second decision that we have to take, whether we do endovascular or open. For focal proximal subclavian stenosis, endovascular therapy is commonly used, and your exam answer should show you understand the planning, access, and risk control. Endovascular subclavian angioplasty or stenting starts with planning, which is based on CTA, MRA angiography. Then you choose access, commonly femoral, sometimes brachial, depending on anatomy. Cross the lesion carefully, angioplasty, and often stent for ostial proximal disease. Confirm vertebral and distal arm flow on completion angiography and monitor for neurological complications. In a symptomatic steel or coronary subclavian steel, revascularization of subclavian lesion treats the cause and resolves the hemodynamic problem. Pitfalls of the complications are embolization causing posterior circulation events, so meticulous technique and awareness of vertebral origin is key. What about open surgery? If endovascular is not suitable, long occlusions, failed stents, complex anatomy, or durable solution needed, you should be fluent with the classic operations such as carotid subclavian bypass or subclavian transposition, and these are standard durable options in selected cases, and you should say you choose based on anatomy and patient's factors. For carotid subclavian bypass or transposition, the key is exposure in the supraclavicular fossa. Protect nearby nerves and lymphatic structures, control the common carotid and subclavian safely, perform the bypass or reimplantation, ensure good inflow and outflow, and confirm distal pulses and neurological status. Now, what are the pitfalls? Nerve injury and local complications, and of course, stroke risk. So, patient selection and meticulous exposure matter. Now let's talk about subclavian steel syndrome. It is due to proximal subclavian stenosis proximal to the vertebral origin, leading to retrograde vertebral flow. Symptoms are often triggered by arm exercise and include vertebro-basilar features, plus arm claudication and an inter-arm blood pressure difference. It is often asked in the exam, how would you clinically test it in your clinic? Sometimes, due to exam pressure, we often forget that simple tests like blood pressure difference could really pick up the clue. Okay, then how would you investigate further? Duplex showing vertebral flow reversal is the key, as I mentioned earlier. CTA, MRA, angiography define anatomy for treatment. Asymptomatic steel does not always need intervention. Symptomatic steel generally needs revascularization, usually endovascular first for focal disease, with surgical options when endovascular is unsuitable or has failed. Now let's talk about coronary subclavian steel, the must not miss. If there is a prior CABG with Lima graft, you say I would specifically consider coronary subclavian steel, where subclavian stenosis causes reduced or reversed flow through the Lima, leading to angina, and treatment is revascularization of the subclavian lesion. That is very important to remember. What to do in real life? When you are on call and you have got an acute upper limb ischemia, you hyperinize early, assess viability. If threatened, urgent revascularization, often brachial embolectomy, and then source control and secondary prevention. In the clinic or MDT, when you get chronic disease, define symptoms, check interarm pressure and neurology. Duplex with vertebral flow direction, CTA or MRA for planning. Treat symptomatic steel or coronary subclavian steel with revascularization, commonly endovascular first, with surgical backup options. Now, let's talk about the management summary, as just to summarize what we have learned so far. Acute upper limb ischemia, what do? You immediately introduce analgesia, systemic heparin, if not contraindicated, classify limb viability, then urgent revascularization if threatened limb. Often brachial embolectomy is the gold standard, post-op anticoagulation, and then don't forget embolic source workup and of course secondary prevention with long-term anticoagulation if required. Now, in chronic atherosclerotic upper limb disease, confirm the anatomy and hemodynamic by doing duplex, including vertebral flow direction, and then CTA, MRA, or angiography. Intervene for symptoms such as arm claudication, limiting function, vertebro-basilar symptoms in steel coronary, subclavian steel, access-related issues. But of course, remember endovascular first for focal proximal lesions, open bypass transposition if unsuitable for or failed endovascular. Okay, and that's all for our upper limb ischemia. Now we will talk about Raynaud's phenomenon, and this is often tested in the written exam. So for Raynaud's phenomenon, because this is a very high yield topic, Okay, so far about Raynaud's phenomenon, because this is a very high-yield topic, particularly in short cases or Viber stations. So for Raynaud's phenomenon, this is often tested in your written exam. Raynaud's phenomenons describe episodic reversible digital ischemia, classically triggered by cold exposure or emotional stress. The traditional description is so-called French tricolor: pelo for vasospasm, followed by cyanosis for static deoxygenated blood, and then rubor due to reactive hyperemia. So, these tricolors, just for you to remember: pallor, cyanosis, and rubor. The way I remember is PCR: pallor, cyanosis, and rubor. Okay? Importantly, the full triphasic sequence is not required for diagnosis. A history of cold-induced blanching alone is sufficient, and attacks may be monophasic, asymmetrical, or involve only part of the digit. Vasospasm may also affect the nose, ears, tongue, or nipples. The recommended terminology is very clear. Use the term Raynaud's phenomenon. The older terms Raynaud's disease and Raynaud's syndrome are best avoided. From an exam perspective, the most important classification is primary Raynaud's phenomenon and secondary Raynaud's phenomenon. Primary Raynaud's phenomenon accounts for 80 to 90% of cases and is much more common in women, often being in adolescent or early adulthood, and frequently has a genetic component. It is generally being conditioned, not associated with tissue loss, although patients may still report a significant impact on quality of life. Secondary Raynaud's phenomenon is less common but far more important clinically. It is associated with an underlying condition, most often a connective tissue disease, and it is the form that can lead to digital ulceration, critical ischemia, and tissue loss. This distinction between primary and secondary Raynaud's is absolutely critical, and in the exam you should have a low threshold for further investigation and specialist referral. In terms of epidemiology, Raynaud's phenomenon affects approximately 5% of the UK population, but prevalence may rise to 20 to 30% in younger women. Primary Raynaud's is around 9 times more common in women, whereas secondary Raynaud's depends on the underlying disease. Now let's talk about secondary cause, because this is where candidates lose marks. Secondary Raynaud's is most commonly associated with systemic sclerosis, but also occurs in systemic lupus erythematosus, mixed connective tissue disease, idiopathic inflammatory myopathies, antiphospholipid syndrome, and vasculitis. Occupational causes are also important, particularly hand-arm vibration syndrome, previously known as vibration white finger, which occurs after prolonged exposure to vibrating tools. This is recognized as an industrial disease in the UK, and symptoms correlate strongly with duration of exposure. Drug-related causes. These are also well described and include beta blockers, chemotherapy agents, vasoconstrictive drugs, and nicotine. Chemical exposure, trauma, and chronic cold exposure may all play a role. Pathophysiologically, Raynaud's phenomenon represents an exaggerated vasoconstrictor response. This involves endothelial dysfunction, increased vasoconstrictor mediators such as endothelin 1, altered nitric oxide balance, and abnormal alpha 2C adrenergic receptor activation in response to cold. In secondary Raynaud's, especially systemic sclerosis, there is also structural vascular disease with intimal proliferation, luminal narrowing, and capillary dropout, explaining why ischemia can become fixed and progressive. Clinically, patients describe cold-induced color change, pain, numbness, or tingling. Red flags suggesting secondary Raynaud's include late onset, male sex, asymmetrical attacks, severe pain, digital ulcers, pitting scars, or any features of connective tissue disease such as sclerodactyly, telangiectasia, malar rash, synovitis, pulmonary fibrosis, or livedo reticularis. For a Vyvanse standpoint, your assessment must be structured and deliberate. Every patient with Raynaud's should undergo capillaroscopy and immunological testing. Nail fold capillaroscopy has become one of the most sensitive tools for detecting an underlying connective tissue disease, particularly systemic sclerosis. Normally, capillaries are uniform, hairpin shaped, and evenly spaced. Abnormal findings include giant capillaries, dilated loops, architectural distortion, microhemorrhage, and areas of capillary dropout. These changes are strongly predictive of progression to connective tissue disease. Combination of abnormal nail fold capillaries and positive autoantibodies is extremely powerful. Patients with both have been shown to be up to 60 times more likely to develop systemic sclerosis. Conversely, normal capillaroscopy and negative autoantibodies carry a very strong negative predictive value with negligible risk of future connective tissue disease. Now, serological testing should begin with ANA, which is antinuclear antibody, followed by disease-specific antibodies where appropriate. Anticentomere antibody strongly predict limited cutaneous systemic sclerosis, while anti-topoisomerase antibodies are associated with diffuse disease. Additional investigations such as infrared thermography, laser Doppler flowmetry, and digital plethysmography may support the diagnosis, particularly in secondary Raynaud's, although these are not routinely required. Now, how would you manage? The foundation of treatment for all patients is lifestyle modification, avoid of cold, smoking cessation, stress management, and protection of the digits. The steps are often underestimated but must always be mentioned. Pharmacological therapy is introduced when symptoms persist or tissue risk is present. Calcium channel blockers, particularly dihydropyridines, are the first line treatment and have the strongest evidence base. They reduce attack frequency, they reduce attack frequency and severity in both primary and secondary Raynauds. In more severe or refractory cases, additional options include angiotensin receptor blocker, SE inhibitors, alpha blockers, phosphodiesterase 5 inhibitors, and prostacyclin analogs, particularly for critical digital ischemia associated with systemic sclerosis. The overall evidence base is limited, partly because treatment outcomes are often subjective, but these therapies are widely used in specialist practice. In secondary Raynaud's, treating the underlying disease is essential. Close collaboration with rheumatologists is critical, particularly in patients with evolving connective tissue disease, vasculitis, or inflammatory myopathy. Surgical or interventional treatments play a very limited role and are reserved for severe refractory cases with threatened tissue loss. Options include digital sympathectomy, but outcomes are variable and should be considered only in specialist centers. So to finish this summary, primary Raynaud's is common, benign and managed conservatively. Secondary Raynaud's is less common, potentially limb-threatening, and demands structured investigation. Early recognition of connective tissue disease and multidisciplinary management, nail-fold capillaroscopy, and immunological testing are central to risk stratification, and calcium channel blockers remains first-line pharmacological therapy. That's the essence of Raynaud's phenomenon: concise, structured, and safe for the exam. Now let's talk about some rapid-fire SPA practice. Okay, ready? Let's start. A 72-year-old with AF present with sudden painful cold hand and absent radial ulnar pulse. Best immediate management. Immediate management would be IV heparin, so remember that clue. Best immediate step. Now, immediate anticoagulation prevents clot propagation while you assess viability and plan urgent revascularization. So when you get this clue in the question, please pick it up and answer immediate step. Next, in acute upper limb ischemia, which clinical finding most strongly indicates threatened limb? The correct answer would be motor weakness or paralysis. We know that already. Motor weakness means threatened limbs. Motor deficit implies threatened viability and need for urgent revascularization. Now, most common lodging site for the upper limb embolus, we already said brachial bifurcation, because that is the classic anatomical site. Next question: a patient has arm claudication and dizziness on using the left arm. Blood pressure on the right arm is 150, left arm is 115. Most likely diagnosis, I think you can guess, left subclavian stenosis with subclavian steel. And we said that symptoms plus significant interarm blood pressure difference suggests proximal subclavian disease. Duplex often shows vertebral flow reversal. Best non-invasive test to support subclavian steel physiology. What is the answer? Duplex ultrasound showing retrograde vertebral flow. Again, this is very important to remember. Next, patient with prior CABG using Lima has exertional angina and left arm fatigue. Big interarm blood pressure difference. Key diagnosis is coronary subclavian steel because proximal subclavian stenosis compromises Lima flow, causing myocardial ischemia. Next, threatened acute upper limb ischemia with suspected brachial embolus. Most appropriate definitive treatment: urgent brachial embolectomy. Here, they asked about definitive treatment. They did not ask you about immediate management. So these are the clue that you need to pick it up in the exam written answers. Okay. Next, in chronic symptomatic subclavian stenosis, which approach is commonly used? We all know that already, endovascular first approach for short focal lesions. Okay, if endovascular treatment is unsuitable or has failed, what would you do? You do carotid subclavian bypass or subclavian transposition, and these are durable surgical reconstruction. Okay, in acute upper limb ischemia, what is the classic don't do mistake? That's you delaying treatment in threatened limb for non-essential imaging. Subclavian steel, where is the stenosis typically located relative to vertebral origin? We know that the only way you can steal blood from vertebral artery if you have blockage proximal to the vertebral origin. So that's the answer. Now let's do some questions about Raynaud's phenomenon. A 24-year-old woman has episodic finger color change in cold exposure with clear triphasic changes. There are no ulcers and systemic review is unremarkable. Best single statement. This is most consistent with primary Raynaud's. And how would you manage? You manage mostly with conservative, mostly with conservative management, as we said. A 52-year-old has Raynaud's with digital ulceration and tight, shiny fingers. What is the most important implication for exam? Treat the secondary Raynaud's until proven otherwise and look for connective tissue disease, such as scleroderma-like features point to secondary causes. The priority is identifying underlying systemic disease. Okay, in Raynaud's workup, which investigation is the most aligned with identifying secondary disease patterns at the bedside or clinical interface? We said about this, the nail fold capillaroscopy or assessment of nail fold microvasculature. That is the main test that you want to do. The textbook emphasizes distinguishing primary versus secondary, and microvascular assessment supports that separation. Since Raynaud is worsening, and where is the concern for systemic disease? Which associated group of condition is explicitly exam relevant? The rheumatological or connective tissue disorders such as systemic sclerosis. That is the correct answer, because secondary Raynaud's is repeatedly linked with systemic disease, and this is a high-yield exam question. Which single feature most strongly pushes you away from benign primary Raynaud's? That is digital ulceration or tissue loss, because this is very rare to have tissue loss in primary Raynaud's. Tissue injury implies more than simple vasospasm and should trigger urgent secondary causes workup. Now let's practice some clinical scenarios. Scenario 1 about acute upper limb ischemia. An elderly patient with no atrial fibrillation present with sudden and severe pain in the arm, cold hand and absent distal pulses. With early sensory change, my approach, so how would you manage? My approach would be, first I treat it as acute limb ischemia and heparinize immediately unless contraindicated, provide analgesia. Then I assess limb viability, focusing on sensory and motor function. And if there is motor function deficit, it means the limb is threatened. If the limb is threatened and presentation fits embolus, I would proceed urgently to revascularization, commonly brachial embolectomy via antecubital exposure, and clearing clot proximally and distally, and confirming return of flow clinically and with Doppler. After revascularization, I would continue appropriate anticoagulation and investigate the embolic source, because preventing recurrence is part of definitive management. Now, what about subclavian steal syndrome? A 65-year-old gets arm fatigue and dizziness when using the left arm. There is a clear interarm blood pressure difference. I would say this sounds like symptomatic proximal subclavian disease with subclavian steal. I would confirm clinically with bilateral arm blood pressure and pulse exam and a neurological screen, then organize duplex to look specific for vertebral flow reversal and map anatomy with CTA MRA if intervention is planned. If symptoms are clearly attributable to steal and the lesion is suitable, I would favor revascularization, commonly endovascular for focal proximal stenosis, with surgical options like carotid and subclavian bypass or transposition if endovascular is unsuitable or has failed. Now let's talk about scenario 3. There's a coronary subclavian steal. A patient with previous CABG using Lima has exertional angina plus left arm exertion symptoms and a big interarm blood pressure difference. I would explicitly raise coronary subclavian steal as my diagnosis. The mechanism is subclavian stenosis proximal to the Lima inflow, so management is aimed to restore subclavian inflow. After confirming the diagnosis with duplex and anatomical imaging for planning, if anatomy is suitable, I would favor endovascular revascularization of the subclavian lesion, and if not, discuss open reconstruction. The examiner point is treating the subclavian lesion treats both arm symptoms and the myocardial ischemia driver. Thank you very much. We are at the end of this episode. Thanks for listening to Proximal Control Vascular Surgery Exam Prep. If you have found this useful, stay tuned, because in the next episode we will discuss thoracic outlet syndrome, a very important topic, and we will talk about important clinical anatomy and management tied back to guidelines, evidence, and practice scenarios. As always, with your support, we will grow together. Keep listening to Proximal Control, because in vascular surgery, control is everything.